And of course, we need to do something about the 95% who are not getting reasonable services. You know, these folks have troubles with all of the issues that I mentioned that reflect the quality of care. And the data are really clear across many, many studies about the seriousness of the problem. And that's in contrast to the fact that, you know, those of us who get funded by NIMH have developed lots of interventions over the years that are truly effective. The problem is just they don't ever get used in the U.S. mental health system. And the problems are getting worse. I think you probably all know that morbidity and mortality related to physical illnesses are getting worse, that mental health funding is getting worse, that the quality of services is eroding around the country. There's more and more shunting of people with mental illnesses into prisons and jails. We aren't making much of a dent in the homelessness situation. There's no mental health system that I'm aware of in the country that's really measuring recovery-oriented outcomes, although they all talk a good game. So the question before us today really is, could shared decision-making affect this situation in some way, improve the situation? So let me say a few words about shared decision-making, and I'm totally delighted that my colleague Pat Deegan is here today to really describe to you in some detail how this might work. Shared decision-making, you know, just means that you have two people who are experts in the room making decisions, at least two people. You have the consumer or customer or client or user of services who is an expert in their own experience and their own goals and what they want, and what their preferences are about treatment and side effects. And you have the healthcare provider who is supposed to know you know, what the evidence is and is supposed to have clinical experience and good judgment about clinical interventions. From the point of view of medical ethics, I hope you all understand that shared decision-making and honoring patient choice is something that we should always have been doing. The first principle of medical ethics is autonomy. And what autonomy means is that we as individuals have rights to make decisions that affect our own bodies. We all have this right. In the rest of medicine, you know, it's honored to a very great degree, but for some reason we've had the belief in the mental health system for years that we should strip that right away from people, and it's pretty rare for people to actually have that right honored. There are lots of practical considerations related to shared decision-making that we can talk about today. There are difficulties in implementing the model, there are policy issues that we've got to face, and I hope we can talk about all of those. I'm going to skip over this. We've mentioned most of those things. Now, there are actually lots of mental health models out there that pay close attention to shared decision-making. You know, there's the critical time intervention model that really reaches out to people who are homeless or otherwise in difficult straits and tries to make sure that people have choices about what they want and tries to connect them with the things that they're interested in. There's the Housing First model, which you know, my friend Samson Barris really initiated in New York, where you know, the first thing they do with a customer who's street homeless is to talk with the person about the fact that they have housing options, and they take them around to visit different apartments and say, well, it's your choice. And as soon as the person picks an apartment, they give them the keys. And of course, they've found, like everybody else, that if you start with what people are really interested in, honoring their choices, they become more interested in other things that involve taking care of their health. There's the illness management and recovery intervention that my colleague Kim Musser has put together, trying to help people learn how to manage their own illnesses, that now has several nice randomized clinical trials showing that it's effective and that people can really be much more independent and learn to take care of their own illnesses. And there's the Common Ground program that Pat will tell you about later this morning, or later today. But let me say a few words about the supported employment. It's one of the things that I've been involved in studying for the last 20 years. And I think it's an interesting model of shared decision making. When I first got asked to by the commissioner in New Hampshire 20 years ago to help develop better employment services, because that's what all of our consumers in New Hampshire wanted, and he, as well as everybody else, knew that the current programs were not very effective. You know, we had only about 10% of our people employed, even though 75% wanted jobs. When I first started looking into this, it turned out all of the employment models that were popular in that time, the sort of Cadillac models, were based on professional and theoretical ideas about training people and teaching them things and guiding them and on and on. They were interventions that professionals liked and could bill for, but unfortunately they weren't what consumers were interested in, and they didn't have any evidence that they actually helped people get jobs. And so we started setting up a whole series of experiments, and it turned out that supported employment, which was a model that we borrowed from developmental disabilities, consistently had better outcomes than all of the Cadillac models that were in the literature at the time. Supported employment is a simple, straightforward model, as are most things that work. It really involves just asking somebody, you know, what kind of job would you like, and trying to help them find a job that's consistent with their preference as rapidly as possible, and then providing whatever support services they need in order to succeed in that job. It's a team approach, you know, so that you really get the person together with the VR counselor and the support employment counselor and psychiatrist and mental health counselor, their family, and everybody puts their head together to try to think about what can work and how can we get this person a job, and as fast as possible, how can we help them. It's all based on client choice. So if the client says, you know, that he wants to work with animals, we don't place them in a grocery store or you know, sweeping floors. We try to find a job in, you know, in a veterinary office or in a pet store or something like that. If the person wants to disclose their illness to an employer, that's his choice, and we go that way. If the person doesn't want to disclose, they don't, and we provide supports off the job site. If the person wants to look for a half-time job, we look for a half-time job. It's all patient-centered. Of course, when I first got into this field, the experts, you know, all told me lots of rules about employment services, like that, you know, it took 6 months of counseling for somebody to select a realistic job. It's just not true. Over 90% of people know what they want to do right away, and it's realistic. People told me that, the experts told me that the most important thing in vocational services was to keep the vocational services separate from the mental health services so that they wouldn't be contaminated by all the stigma of mental health and low expectations and all of that. And you could really have people who are professionals in vocational services doing work. That's a very nice theory. It just turns out to be completely wrong in practice. You know, there are about a dozen studies now comparing integrated and parallel models, and the integrated models all do much better. So it really is important that we study these